I'm delighted now to invite up our next speaker, that's Professor Laurence Sperling, who is a professor in Preventive Cardiology at the Emory University School of Medicine. He's also a professor of global health at the Rollins School of Public Health and the executive director of the US Federal CDC Million Hearts Program for the Division of Heart Disease and Prevention Association. But he's not speaking in that capacity today, but he bears many hats and has an incredibly distinguished career. He's also going to take us through, again, this focus on early detection and diagnosis. Professor Sperling, the floor is yours.
Thank you so much. It is really an honor to be here. This is a very important gathering, and just grateful to be a part of it. So I was asked to discuss the public health and health system perspective. Importantly, I have no conflicts related to my presentation today. My comments today reflect my specific comments and not those of the organizations I work for, work with, or serve. So in my time with you, I'd like to emphasize the challenges before us, but I'll only spend a short time there because I really want to highlight the solutions and the actions. That's why we're here. So we heard about some of these challenges, and over the past 3 decades, cardiovascular disease, ischemic heart disease has snuck up on us as public health endeavors have improved. Ischemic heart disease has been the #1 cause of death in the world. And you can see in the right lower panel the impact of that on a global level. Thankfully, I've been involved with the World Heart Federation now for over a decade, and Salim Youssef, who was president back in 2013, made this comment at a meeting in Rome that cardiovascular disease is the biggest epidemic, in fact, a pandemic, ever known to mankind. And so we need strategies to address epidemics. This is truly a health and healthcare crisis, and this is urgent. And again, that's why we're here. Well, over the past number of years, we have been challenged by a global pandemic. And the impact of this pandemic, as you well know, was, of course, the acute impact of an infectious disease, but the secondary impact of this infectious disease on chronic diseases. And this pandemic is not over. The consequences of this, and hopefully the lessons learned, will be long-lasting. This figure depicts what I call converging syndemics. We know about the epidemic of chronic diseases and lack of health globally, the health and healthcare disparities, and these were challenged in an unprecedented way by an infectious disease. Shortly after March of 2020, I wrote this commentary in one of our heart journals, Circulation, about the future of cardiovascular disease prevention, and I commented that the risk for COVID-related morbidity is driven by an interaction of a viral illness with an unwell population, and we will need to invest more than ever in essential services like cardiovascular disease prevention, population health initiatives, and robust public health programs. So that's where we are. Where do we need to go? What are the solutions and what are the actions? What must be different? We heard about the importance of the voice, and we're going to keep coming back to that voice. We need accountability, innovation, we'll hear about that during the summit, alignment of incentives, and we need action and action plans leading to equitable implementation. So how do we promote and address global cardiovascular health? This is, again, why we're here. The importance of the patient and community voice and the stories from the heart cannot be underappreciated. We know the challenges. We need the solutions, and we need policy action and investment prioritization. We've worked with Health Policy Partnership, many of us, and again, it's been a great honor to work with this important organization and their staff. This publication last year talked about the policy priorities for cardiovascular disease: healthy aging, We need to think across the life course and hopefully improve health, but also the health span. We need to engage the workplace and understand the potent impact on the workplace, health system resilience. Hopefully, we're learning some lessons from the pandemic and coming back to health equity. I'll point out, and this is an area that we often don't think about, that the air we breathe, the environments we live in are also not equitable. And here, cardiovascular disease is greatly impacted by our environment, particle pollution. I looked up the air quality index yesterday in Barcelona. It's 55. So it's not ideal, but it's also not in the red danger zone. But patients living with heart disease, people living with heart disease should be aware of the AQI just like they should their other risk factors. So we need individual approaches, but we also need systems approaches and policy approaches to our environment and particle pollution. We published this paper maybe 8 years ago now, and it talked about the health disease continuum. I'm a cardiologist, I'm a preventive cardiologist, but for the most part, many cardiologists in the cardiovascular community, we identify disease late. What we need to understand better more and more is what does it mean to be healthy, and how do we focus on early disease detection and diagnosis. We've already heard several times about the social determinants of health. We published this paper, and of course, we want to think about traditional cardiovascular risk factors, as Dr. Wood pointed out. These can be identified and treated, and we can prevent cardiovascular disease, but we also need to identify access to care, healthy foods, psychosocial, behavioral, and environmental factors. In fact, the preferred terms are not social determinants of health, but drivers of health and factors that are not predetermined. So these are influences of health, but we can change this trajectory. We published this paper. It was the first gathering at the Heart House in the US, talking about the Cardiometabolic Alliance. And if you've not heard about cardiometabolic disease, 1 out of every 3 or 1 out of every 2 adults across the world have cardiometabolic risk. A constellation of factors related to visceral adiposity, cholesterol abnormalities, high blood pressure, prediabetes, leading to what can be early heart and vascular disease, not only of the blood vessels, but of the heart muscle, and the constellation of heart concerns that we'll hear about throughout the summit. Thinking about stages related to this cardiometabolic risk is really important in terms of how to address it, both on an individual level, a health system level, and a public policy level. Well, a sneak preview. From here, I'll be heading to the American Heart Association meeting. Over the past year, we, a large group from AHA, have worked on the CKMH initiative. Publications just a week or 2 ago, a presidential advisory, a scientific statement, and we will be launching a very unique integrated calculator, risk calculator. And this CKMH, metabolic health, is a really important focus on a global level because many, many people are living with pre-disease. So coming back to the importance of early detection and diagnosis. Dr. Pinto mentioned the roadmaps from WHF, really, really important focus, really important documents. I was honored to chair the roadmap on cardiovascular disease prevention among people living with diabetes. We presented this BC before COVID at the ESC meeting in 2019. This document, we developed an ideal pathway of care, 5 different populations, again emphasizing early diagnosis, early detection. And what was unique here is the patient perspective across the world and the focus on implementation and implementation science. So that patient perspective, we must listen better, and we need that voice. We need to understand challenges with accessibility, acceptability affordability, and availability. So who are roadmaps for? They're for people living at risk for heart disease and with heart disease as a greater community. And it's all about implementation. It's not about publications of scientific documents. So these roadmaps are living and breathing. They can be used at a community level or a country level. And just as an example, the last roundtable we had in Ghana, you need to engage the Minister of Health, need to understand the culture, the importance of engaging traditional healers, and developing cardiovascular disease scorecards. A couple of examples of things we're doing in the US related to innovation in early detection and diagnosis. The university I work at, we are one of 5 sites in the US related to a national initiative called Find FH, familial hypercholesterolemia, present in 1 out of 250 individuals everywhere in the world. And we can use big data, machine learning algorithms to find, flag, identify, network, and deliver familial hypercholesterolemia before manifest cardiovascular disease. And so with an R-squared value of about 0.8, we can detect these people. But then we have unique challenges at a systems level. But instead of screening 2,000 people, we can find FH and find the family members of people living with FH early. Another initiative in the US is the rural cohort study that we're involved with. The US considered a high-income nation, but we have great disparities. And there are many areas in the US that are the equivalent of low and middle-income countries, especially vulnerable populations within our cities and rural areas. And so we are working on the rural study to better understand these small communities, their resilience, but also the allostatic load of risk over the life course. This was just published, I believe, yesterday, a commentary we wrote about primary ASCVD prevention, optimally active, agile, and accountable, all the way from those at highest risk to lowest risk. So how do we think about national plans for cardiovascular disease prevention? I want to pay attention to my time. This is a document you can access related to health policy partnership, but in yellow here, related to the theme of our meeting, in terms of these key prominent plans, really important parts of them include screening and early detection, risk factor management, and early diagnosis. So we must identify, ideally before disease. We can address this risk through population-level screening and early detection, but I must point out, putting my public health hat on, that screening and detection needs to be connected to clinical care, not in isolation. But as Dr. Wood pointed out, timely preventive therapies matter. I noticed this at the ESC meeting. I've got the red light on. I'm hopefully turning the corner here to finish my presentation for the panel. But at the ESC meeting, this caught my attention. The ESC Cardio Policy Group and ESC together is bringing together national cardiac societies for action. As mentioned, I serve as the executive director of the U.S. Million Hearts Initiative. I'm going to speak on behalf of the initiative, not for the initiative in this forum, but Million Hearts is a CDC, CMS co-led initiative. It's funded by appropriations from our Congress, and Million Hearts is all about, we have proven and effective strategies to prevent 1 million heart attacks, strokes, and cardiovascular events in our nation in a 5-year cycle. This can be done in other nations, and this can be done globally. Our priorities are building healthy communities, optimizing care, we call this the ABCs, and a central focus on health equity. All of our priorities are not just about information and education, but they're focused on action, very specific, actionable steps by which we can, it's an example of possibilism, prevent 1 million heart attacks, strokes, and cardiac events. I was asked to talk about public health and health systems approaches. During the meeting, we'll learn about precision medicine. How do we take science, innovation, discovery, bring it to each unique individual across the world. That's called precision medicine. There's a concept called precision public health, which is providing the right intervention to the right population at the right time. So as we think about the future needs to be not only looking at clinical prevention, community prevention, but the intersection of these communities on behalf of those at risk for heart disease and living with heart disease, which, by the way, are most adults in the world. So we come back to epidemics and pandemics. Cardiovascular disease is an epidemic and it's a pandemic. And so we must think along these lines to address them. As we have our breakouts, we need to think about how do we identify the vectors, the causes, the barriers, the roadblocks. But moving forward, our goal should be control, elimination, and eradication, very much like we think about a global pandemic like COVID. So I thank you for the invitation and opportunity to speak with all of you. Look forward to our panel discussion. This is a really important gathering, and treat it so. Thank you.